Hello everyone, I'm Dr. Poonam. I am a faculty of Human Anatomy at Medicoz community. I welcome you all in the session on Anatomy Recall Questions of NEET PG 2023. So before starting the session, let's have a little analysis about the exam, especially the anatomy part. So it had a mixed bag of questions. Most of the questions were clinical based. Very few questions were from the core anatomy. If we will talk about the reason of the anatomy, so questions were from head and neck, neuroanatomy, embryology, upper limb as well as from the lower limb. So now you all know the questions and answers to them. So today in this session, I'm going to tell you not only the answers, but I'll also discuss the important points related to the particular topics from where the question were asked. Since it is a recall session, so you may find variations in the pattern of the question, in options, images, as well as in the language. So if you guys have any suggestion, you can put your comment on the comment box. Okay. So let's start with the today's session. Okay, so here comes the first question, that is a case of jaw arrested or yawning, which muscle is attached to the articular disc of temporomandibular joint. So here we have a case that is stuck jaw on yawning, which means opening of the mouth, and opening of the mouth is caused by the depression of the mandible. So whenever there is excessive depression of the mandible due to the spasmodic contraction of the muscle which is causing the depression of the mandible, it will lead to the condition that is stuck jaw. Clear? Then we have the next point here, that the muscle is attached to the articular disc of temporomandibular joint as well. Okay, so before going to the options, I want to show you this diagram here. Yes, so this is the image here which is showing the temporomandibular joint, okay, where you can see the head of the mandible. It is here within the mandibular fossa of the temporal bone. Anterior to this temporomandibular joint, there is the tubercle which is called as the articular eminence or articular tubercle. So basically this articular tubercle, it prevents the anterior displacement of the head of the mandible. So that's how the head of the mandible, it will remain into the mandibular fossa there. Clear? But whenever there is a spasmodic contraction of the muscle which will cause the depression of the mandible, so in that condition, or in the excessive opening of the mouth or depression of the mandible, this head of the mandible, it comes out anterior to this articular eminence here. Okay, and this condition is called as the anterior dislocation of the temporomandibular joint, where the jaw is stuck and the mouth that will remain open. So in this condition, the patient cannot close the mouth until and unless the pressure is given downwardly and posteriorly on the mandible here. So that's how, this is the technique basically which is done to cure this condition here. So here we have the anterior dislocation, and it is the most common dislocation of the temporomandibular joint. So that stuck jaw condition is the opening of the mouth, and due to the excessive opening of the mouth, you can say, and there is the depression of the mandible, and head of mandible, it comes out from the mandibular fossa, and it comes out where? Anterior to this articular tubercle or articular eminence, and that's how it cannot go back. Okay, so the case is here, that is the anterior dislocation. Now there is the another image which is showing the temporomandibular joint here. This is the side view basically. Here you can see the joint cavity here, and within the joint cavity we have this articular capsule cartilage here, which is dividing the joint cavity here, joint cavity of the temporomandibular joint, and then here we have the capsules of the temporomandibular joint. Now you can see there is a muscle here. So this muscle is called as the lateral pterygoid muscle. Okay, so this muscle, it is taking origin from this point here, that is from the lateral surface of lateral pterygoid plate. Then both head, they will go backwardly here, and then some fiber they will attach to the capsule of the temporomandibular joint, and some fiber, inferior one, they will attach to the pterygoid fovea here. So basically the pterygoid fovea, it is a small depression which is on the front of the neck of the mandible here. Clear? So here we have the capsule of the temporomandibular joint, where you can see there is the attachment of this lateral pterygoid muscle here. Okay. Now it is believed that the articular cartilage which is here, okay, articular disc, basically it is the extension of the lateral pterygoid muscle. Clear? So now we will see the question here. Yes, so here the case of jaw stuck here, and we have to identify the muscle that is attached to the articular disc as well. So now we have got the answer for this question, that is the lateral pterygoid muscle. It is attached to the articular disc of the temporomandibular joint, as well as this muscle, it also helps in the depression of the mandible. So this muscle, the spasmodic contraction of this muscle is the cause of this stuck jaw here. Clear? So the correct answer for this question is lateral pterygoid muscle. We have masseter, medial pterygoid and temporalis here, but these MMT muscles, they are the elevators of the mandible, which will help in the closing of the mouth, as well as the temporalis muscle here, the posterior fiber, they help in the retraction of the mandible as well. Okay, so this is our question here, and the answer for this is the lateral pterygoid. Now we will see the next question, that is, yeah, so this is the image based question here. This is not the clinical question, this is just the image here. This is the image of endoscopic view, that is of the nasopharynx. Okay, and the arrow marked structure here, we need to identify this area. So for that we will see the anatomical image of the lateral wall of the nose. Okay, so here you can see this is the lateral wall of nose, and here we have, this is the nasopharynx. Now for the endoscopy, the tube, it will enter through this passage here, and then it will passes like this. As soon as this tube, it will cross the inferior concha. Okay, this tube will enter into the nasopharynx. Okay, so now here we will see all the features, they are present here within the nasopharynx. So first of all, there is this opening here, which is called as the opening of the auditory tube and eustachian tube. Okay, and superior to it there is this elevation, which is called as the tubal elevation. Anterior to it, I hope you can see these two folds, anterior and posterior to this auditory opening here. So anterior fold is called as the salpingo-palatine fold, and the posterior one is called as the salpingo-pharyngeal fold. So basically these folds appear here due to the folding of the mucosa. So here within the folding of the mucosa, the muscles, they are present here. So under the fold of this salpingo-palatine muscle, there is a salpingo-palatine fold, there is a muscle with the name of tensor veli palatini. So what is happening, there is a muscle, tensor veli palatini, and the mucous membrane, it is overlapping it, and the fold will form here, and the name is salpingo-palatine. Salpingo means auditory tube, so this fold is extending between the auditory tube and the palate, so the name is given salpingo-palatine. So there is another mucosal fold which is called as the salpingo-pharyngeal. So in the salpingo-pharyngeal fold, inside it or within it, there is a muscle of same name, that is the salpingo-pharyngeal, and then there is the overlapping or covering of the mucous membrane here, and it will form a fold that is called as the salpingo-pharyngeal fold. Okay, now posterior to this salpingo-pharyngeal fold, if you will see, there is a depression here. So there is not a depression, so this is a area here. Okay, a small space here, and this space posterior to the salpingo-pharyngeal fold is called as the pharyngeal recess, which is also known as the fossa of Rosenmuller. Okay, so here we have a space posterior to the salpingo-pharyngeal fold, and that is called as the fossa of Rosenmuller. Now we will see this endoscopic image here. Yes, so this is the nasopharyngeal part here. Here we have the opening. Obviously this is the auditory tube opening. Clear? Anterior to it we have a fold. What is the name? Salpingo-palatine fold. Posterior to it, this fold is called as the salpingo-pharyngeal. The elevation is here, that is the tubal tonsil, and posterior to the salpingopharyngeal fold, this space which is marked here, so this space is our fossa of Rosenmuller or pharyngeal recess. Okay, so the answer for this image based question is the fossa of Rosenmuller. Okay, so these are the options here. So tonsil is here, then we have tube, this auditory tube opening, eustachian tube opening, and fossa of Rosenmuller is the answer, and the adenoid tissue. I'll show you where you can see the adenoid tissue. Yes, towards the roof. So this is the area where you can find the adenoid tissue. Clear? So the answer for this question is fossa of Rosenmuller. Now the next question is, so there is a case of 50-year-old patient who is presented with the history of fall 1 week back. Okay, so this is the chronic case here. The history is 1 week for fall 1 week back. So this is the chronic one. Now the patient is presented with the confusion, headache, ataxia and the dizziness. So there is a history of chronic alcoholism as well. Okay, so the NCCT image is given here. And what is the diagnosis? So first of all, this image, it is in the first appearance, this image is giving the finding of the subdural hematoma and epidural hematoma. Okay, so there is a confusion between the subdural and epidural hematoma here, if you will see this image here. But before that, I want to show you this diagram here. Yes, so here you can see again the subdural and the epidural hematoma is here. So you can see the difference here. In subdural hematoma, where it can occur deep to the dura mater. Okay, basically in the subdural hematoma, the venous blood is there, okay, which occurs due to the tearing in the bridging veins here, and you can see it is crescentric in shape and more expanded. Yes, now see the epidural hematoma here. The epidural hematoma, it is outside the dura mater but inside the bony table here. Okay, and this is limited by the sutures here. Okay, and the blood which is here, that is not the venous, this is the arterial blood which occurs due to the tearing of mainly anterior division of middle meningeal artery. So you can see the shape here of this hematoma. So this is biconvex in shape and it is not expanded. Okay, so this is the, so these are basically the difference between subdural and epidural hematoma. Now we will see the CT finding here. Yes, so here you can see this is the area of the hematoma here. It can be epidural hematoma, but the hint is here in the question, that is there is the history of fall 1 week back. So this is not the acute case, this is the chronic one, and in case of that chronic case there is a chance of the subdural hematoma. So this is the finding which is our subdural hematoma. So this is the answer for this question here. Apart from the SA subarachnoid and the intracerebral hemorrhage, they are again there will be the acute, these will come with the immediate findings here, immediate fall or immediate injury. So it can, these cannot be the answer for this question. The subdural hematoma is the answer here. Okay, now the next question is, yes, so again this is the clinical based question here related to your neuroanatomy. So there is an injury to lateral part of dorsal column of cervical region results in loss of proprioception in. So before going to the options, we will see this image here. Okay, so here you can see this is the cross section of the spinal cord, this is the gray matter, and surrounding it we have the white matter here. This is the posterior white column, this is the lateral, and this is the anterior white column here. So here within the posterior white column, because it is specified in the question, there is the injury into the lateral part of dorsal column. So in the posterior white column we have two tracts here, fasciculus cuneatus and fasciculus gracilis. Okay, so fasciculus gracilis, it occupies the medial part and the lateral part is occupied by the fasciculus cuneatus. these two tracts, they are carrying the sense of proprioception, out of which the fasciculus gracilis, it is carrying the sense of proprioception from the lower limb, and cuneatus, it is carrying the sense of proprioception from the upper limb. They are also carrying the vibration sense, okay, some amount of pressure and fine touch. Clear? So here you can see the fiber, they will travel through this posterior root of the spinal nerve, then they will directly enter into the posterior white column here. So these are the fiber, they are from the upper limb, so that will occupy here, that is occupying here the lateral part of the posterior white column, and the medial part is occupied by the fasciculus gracilis, okay, and it is carrying the fiber from the lower limb here. Then these fibers, they will ascend upwardly and then they will enter into the medulla. At the level of medulla, you can see here these fibers, they will undergo the decussation. So this is the peculiarity here, this is the important point here. The fiber, they are decussating where? At the level of the medulla. Okay, so we have the scenario here, the injury is at the level of the cervical part of spinal cord. Yes, so what area is affecting here? Lateral area. So lateral area is containing what tract here? That is the fasciculus cuneatus. So proprioceptive sensation from the upper limb will be affected here. Okay, now what it will be? Ipsilateral or contralateral. For that, you can see here the fiber at the level of the medulla, they are relaying here into the nucleus gracilis and cuneatus respectively, and then they are decussating. So the injury, it occurs at the level of the cervical part of the spinal cord, so definitely it will be the ipsilateral side, because in this part the fibers are running on the fibers are running ipsilaterally. Okay, so it will affect the ipsilateral upper limb. So this is the answer for this question here. So ipsilateral upper limb, not lower limb, because it is concerned with the fasciculus gracilis, which is on the medial part here. Contralateral lower limb and upper limb cannot be there, because the fiber, they are decussating after the level of the medulla. Yes, if there is injury at the level of the pons and the midbrain, so there can be the contralateral upper limb, contralateral lower limb and the upper limb proprioception will be affected there. Okay, but here we have the case where the injury occurs at the level of the cervical area. So the answer is the ipsilateral upper limb. Now we have the another question here, that is a 75-year-old female has presented with inability to express feeling, which means mask-like face, bradykinesia or hypokinesia will be there, which means inability to initiate and stop the movement here. Rigidity will be there, and the tremor is there. Okay, tremor will be the pain rolling tremor might have there, and the rigidity, that is cogwheel and lead pipe rigidity will be there. So we need to identify which structure is involved here. So all these symptoms, they relates to the basal ganglia. Okay, so the answer for this is the basal ganglia here. Now hippocampus, it cannot be, because it is concerned with the memory, or basically the short-term memory. Cerebellum, muscular coordination. Internal capsule, it is giving passage to the ascending and descending tracts, so definitely it will affect these tracts here, the function of these tracts. So the answer is the basal ganglia. Okay. Next question is, a patient presented with swelling and pain near the left ear lobule. So this is the area which is affected here. So which nerve is responsible for this pain? So we all know, now this is a very simple question here, and the answer is this question for the nerve which is supplying this area. So the ear lobule, the skin over the angle of mandible and skin over the lower part of the parotid gland, that is supplied by a nerve, and that is the greater auricular nerve. So this is the greater auricular nerve, which is rising from the cervical plexus with root value C2 and C3. So that nerve is supplying this area here. So it will be responsible for the pain in this area. So the answer is greater auricular nerve. Now there is since it is a recall question, no, so there is one more question related to this one, that is I'm not sure about that question. That is related to the swelling and pain in this area, and what is the anatomical basis for the pain in this area here. So in that case, what can be the anatomical basis here? So in this area we have the parotid gland, which is covered with the fascia here, which is called as the parotidomesenteric fascia. Now this parotidomesenteric fascia, it is the extension from the investing layer of deep cervical fascia. Yes. So what happens, this parotidomesenteric fascia, it is unyielding in nature. Okay. So what happens whenever there is any kind of inflammation in the parotid gland, so this fascia, hence it is unyielding in nature, it will not allow the expansion of the parotid gland, which will lead to the severe pain, and it will stimulate the greater auricular nerve here, and that will cause severe pain. Okay, so anatomical basis, the anatomical reason for this pain is the investing layer of deep cervical fascia, and the nerve which is responsible for pain, that is the greater auricular nerve. So there is a difference between the nerve involved here and the anatomical basis for this pain. So these are both different questions here, so you just need to understand this point here, and you just need to focus on the question, the points that is given, the point that is given there, like whether it is asked about the anatomical basis, or just they are asking the direct question in a form of nerve or muscle or gland. So this is the point here. Okay, so we have the next question here, that is a 5-year-old child with acute tonsillitis and ear pain. Now we need to identify which nerve is responsible for the ear pain here. Clear? So hence it is the case of tonsillitis here. So the posterior part of tongue, or the most posterior part of the oral cavity, where our posterior 1/3 of the tongue is there, the palatine tonsil and soft palate is there. So this all is supplied by the glossopharyngeal nerve. Okay, so the posterior 1/3 part of the tongue, the mucosa over here, the taste sensation and the general sensation, that is carried out by the glossopharyngeal nerve. Now this glossopharyngeal nerve, it is also giving secretomotor supply to the parotid gland as well, via a tympanic branch, which is called as the Jacobson's nerve here, and this tympanic branch, it is also supplying your ear here. Clear? So clearly the answer for this question is the tympanic branch of glossopharyngeal nerve is involved here in case of this acute tonsillitis and the ear pain, that is due to the tympanic branch of glossopharyngeal nerve. So this is a very simple question here. If you know the nerve supply and its branches here, then you can identify the correct option here. Yeah, now we have the next question. This is the question from the aortic arteries. Okay, basically the pharyngeal arches. So this is a very important topic. So the question is, which aortic arch is responsible for this defect, which is shown in the image here. So here we have the defect here, which is marked here. So this is the patent ductus arteriosus. So this patent ductus arteriosus, it is due to involvement of which arch artery here. So for that we will just see this diagram here. Okay, so here in this diagram you can see this is the truncus arteriosus, which is dividing into pulmonary trunk and the ascending aorta. Here we have the dorsal aorta, right and left dorsal aorta, and in the lower part they are joining with one another and they are forming the common aorta here. And then we have these arch arteries, they are joining the this aorta, this ascending aorta with the right and left descending aortas here. Clear? So we have first arch artery, second, third, fourth, fifth and sixth. The fifth one, it disappears here. So we will see the remnant of these arteries here. We will see the derivatives here. So the first artery, okay, the first arch artery will form the maxillary artery. Okay, the second arch artery, it is forming the remnant, that is the stapedial and the hyoid artery. Clear. The third arch artery, it is forming the common carotid, which will continue as the internal. So the third arch artery, it gives rise to the common carotid and the internal carotid artery. The fourth arch artery, now you can see we have different derivatives of fourth arch arteries on the right and the left side. On the left side, it is forming the arch of aorta, and on the right side, it is forming the right subclavian artery. Now the fifth one, it disappears here. So now we have the sixth arch artery, which is the important point here. So you can see on the right side and left side, we have six arch arteries. The proximal part of the sixth arch arteries, on each side it is forming the pulmonary artery, and on the right side, this part, okay, which means the distal part of this sixth arch artery, it disappears, and on the left side, this distal part of the sixth arch artery, it is forming the ductus arteriosus. And for the fetal life, this ductus arteriosus is functional, but after that, after the birth, this ductus arteriosus, it will form a ligament here, which is called as a ligamentum arteriosum, which is the usual remnant of this ductus arteriosus here. But if there is the abnormal condition, that is the ductus arteriosus, if it will remain open, then the condition is patent ductus arteriosus. So the patent ductus arteriosus, for this defect, which arch artery is responsible? The sixth left arch artery, especially the distal part of it. Clear? Now we will see the options. So we have sixth left, fourth right, and sixth right. So the answer for this question is sixth left arch artery, particularly the distal part of this sixth left arch artery is responsible for this defect here. Okay. Now we have the next question, which is again from the embryo here. So here the following marked congenital anomaly will develop into. So here this structure is marked here. So here you can see this is the craniocaudal folding of the embryo. This is the foregut, midgut and hindgut here. So from the hindgut here, we have the extension, which is called as the allantois. Okay. So this allantois, the marked structure is here, that is the allantois. Now what happens, in the process of the development, the proximal part or the basal part of this allantois, it absorbed to form the urinary bladder, and the distal part, it will get fibrosed and it will form the structure which is called as the uricus. Okay. Now what happened, this uricus, it will form a ligament which is called as the median umbilical ligament. Okay, so median umbilical ligament is here in the option, and this is the answer. This is the very simple question here. If you know the remnants and the look, I'll show you this diagram here, you will come to know about it, how important it is. Yeah, so here you can see this is the urinary bladder. This is the apex of the urinary bladder. From the apex of the urinary bladder, this extension is going towards the umbilicus. So here this is the uricus, okay, and the lower part of this allantois is forming the urinary bladder, and the distal part is forming the median umbilical fold. So there is basically this is the anterior abdominal wall, and you are seeing it from the inner side, and there is a covering of peritoneum. So this peritoneum, it forms a fold over it, and that fold is called as the median umbilical fold, which is basically due to the uricus here, okay, a distal part of the uricus. Then lateral to it, we have two more folds here on each side. They are called as the medial umbilical fold. So there is a difference, median and medial. Median, which is in the midline, and medial side to it. So this is the medial umbilical fold, which is containing the obliterated umbilical artery inside it, and there is again the fold of peritoneum over it. Peritoneum will cover it and will form a fold which is called as the lateral umbilical fold. most laterally, if you will go here further, so you will see there is another umbilical fold which is called as the lateral umbilical fold, and it is containing a vessel in it which is inferior epigastric artery. So again, the fold of the peritoneum is over the inferior epigastric artery here, and that is called as the lateral umbilical fold. Okay, so this is the point here. So this marked area here, the marked congenital anomaly which develop from into it, that is the median umbilical ligament here, and we have discussed these 2 points here. Now the falciform ligament, again you can see here, this is the reflection of the peritoneum on the liver, and it divides the anterior surface of the liver into the right and left lobe. So here you can see this is the falciform ligament. Okay, so this is not related to the uricus here and the allantois. The correct answer for this is the median umbilical ligament. Now we have the next question. There is a marking over this opening here. Okay, and the question is we need to identify in which layer this opening is present. Okay, so as you can see here, this is the area, this is the structure which is lying over the inguinal ligament here. Okay, and above the inguinal ligament, we all know there is a canal which is called as the inguinal canal. Now this inguinal canal has two opening. Laterally, the opening which is present here, that is called as the deep inguinal ring, and medially that is called as the superficial inguinal ring. So the marking is here on the deep inguinal ring here, which is formed by the defect in which layer? In the fascia transversalis. Okay, so the answer for this question is this defect which is here marked here, that is present into the fascia transversalis. So this is a very simple question here. Now there is one more question which is related to this area, related to this inguinal canal on superficial and deep inguinal ring, that is the hernia, that direct or indirect hernia is there. So here we have the question which is related, which is similar to the previous one. So here the case of hernia which is lying medial to inferior epigastric artery and superior to the pubic tubercle, and we need to identify this hernia. It occurs due to the weakness of which of the following structure? Clear? To see the answer, to know the answer, we will just see this image here. So here you can see this is the inguinal ligament here, and these are the abdominal muscles. This is the external oblique muscle here. Okay, and this is the aponeurosis of the external oblique. Here you can see within the aponeurosis of the external oblique, we have this opening which is called as the superficial inguinal ring. Okay, then we have this inguinal ligament here. So we all know this inguinal ligament, it is formed by the folding, inward folding of this external oblique aponeurosis. Okay, then deep to the external oblique aponeurosis, we have the internal oblique and the transversus abdominis. Now you can see as these two muscles, they passes over the inguinal canal, they arch over the inguinal canal, they are forming the roof of this inguinal canal. Now we have this structure here which is the fascia transversalis, and clearly you can see at this within this fascia transversalis we have an opening here which is our deep inguinal ring, and in between the superficial and deep inguinal ring, this is the inguinal canal, and the roof of this inguinal canal which is formed by the transversus abdominis and internal oblique muscle. When these two muscles, they arch over this inguinal canal, they will go posterior to this inguinal canal, and then their tendon will form a structure here which is called as the conjoint tendon. Now it is clearly identified here. This conjoint tendon, it is forming the posterior wall of the inguinal canal. Okay, so here we have a case of hernia which is lying medial to inferior epigastric artery and just above the pubic tubercle. Yes, so the hernia which is medial to inferior epigastric artery and just above the pubic tubercle, that is the direct hernia, okay, which in which the contents the abdominal content they bulge out through this superficial inguinal ring, and the hernia which occurs through the deep inguinal ring, that is called as the indirect hernia. Okay, so clearly we have the case of the direct hernia here, where the abdominal content, okay, they comes out from the deep inguinal ring. Now if there is weakness of this conjoint tendon which is forming the posterior wall of the inguinal canal, so the abdominal content they will push this conjoint tendon here as it is already weak. So along with the conjoint tendon, the content they will come out from the superficial inguinal ring, and this is condition which is called as the direct inguinal hernia. So here it is basically occurred due to the weakness in the conjoint tendon. So now we will see the options here for this question. Yes, so we have the option of the lacunar ligament, pectineal ligament, inguinal ligament, reflected part of inguinal ligament, and conjoint tendon. So as the conjoint tendon, it is forming the posterior wall of this inguinal canal. So weakness of this conjoint tendon will lead to the direct hernia here, and this is the answer for this question here. Weakness of the conjoint tendon will lead to the hernia which is lying medial to inferior epigastric artery and superior to the pubic tubercle. Now we have other options like lacunar ligament, pectineal ligament, and reflected part of inguinal ligament. So lacunar ligament and the pectineal ligament, they are basically the modification of the inguinal ligament. They are towards the floor, and this inguinal ligament reflected part, it is towards the posterior wall, but it is more towards the midline, so it cannot be the answer here. So the answer is the conjoint tendon. Okay, yes. Now the next question is loss of sensation over the radial 3.5 digits of the palmar aspect of the hand. Which side and the test is correct answer for this from the given options. Clear? So there is a loss of sensation over the palmar aspect of the hand. Okay, on which side, on which digit? Your lateral 3.5 digits. So this is a very simple question here. Clearly the median nerve is affecting here. That's how it is. There is a loss of sensation over these 3.5 digits, lateral 3.5 digits on the palmar aspect, and these medial 1.5 digit on the palmar aspect, they are supplied by the ulnar nerve. So clearly this is the case of the median nerve injury here. Now the options, they are the carpal tunnel syndrome, carpal tunnel and the Fomin test, Guyon's canal and the Fomin test, and the Guyon's canal and Durkin test, and carpal tunnel and the Durkin test. Now we all know through this Guyon's canal the median nerve is passing, okay, and there will be the entrapment of the median nerve, so ulnar nerve here. So the Guyon's canal, it is inferior to that vasohamate ligament here, so it cannot be the option here because we are talking about the injury to the median nerve. So we will rule out these two options related to the Guyon's canal. Now we are left with the carpal tunnel and two tests. Clear? Now we need to identify which test is for the median nerve here. For that, we will see, look, this is the image which is showing the distribution of the median nerve on the palmar aspect and the dorsum of the hand. On the palmar aspect, the palmar cutaneous branch, it is supplying the skin over the palm, and the digital branches, they are supplying the skin over the lateral 3.5 digits on the palmar side, and on the dorsum of the hand they are going to supply the skin over the nail bed. Okay, now this is the so these are the pictures of the Fomin test or Durkin's test. So here this is the Durkin test. Okay, so what is happening here, the therapist with both thumb placing over the distal part of the flexor retinaculum, which is particular this side of the carpal tunnel here, and then the pressure will be applied over this area, and the patient will feel the tingling sensation of lateral 3.5 digits over the distribution of the median nerve. Okay, so in this case the this sign will be positive for the median nerve injury. Then we have the next test, which is the Fomin test here. So this is basically called as the card test. You will ask the patient to hold the card between the thumb and the index finger, clear, and the patient will hold the paper like doing the adduction of the thumb, okay, by moving your thumb towards the other digits, and that's how the patient will hold the card if everything is normal here. That is due to the adduction. Adduction is called by the adductor pollicis muscle here. So if the adductor pollicis muscle, which is supplied by the ulnar nerve here, okay, if that is working properly, then the patient will hold the card like this. Now if there is any problem with that muscle due to injury to the ulnar nerve here, so patient if you will ask the patient to hold the card between the thumb and the index finger, the patient will hold the card, but he will do some trick movement here. So what he will do, he will flex the phalangeal joint of your thumb, okay. So interphalangeal joint of the thumb, it is flexed by a muscle here which is called as the flexor pollicis longus, which is the muscle of the forearm, and this muscle is supplied by the anterior interosseous nerve, which is a branch of median nerve, okay. So in that condition, to hold the piece of paper between the thumb and index finger, the patient will do this trick movement here, and that's how you will come to know there is some problem with the ulnar nerve, and in this case this sign is the positive for the ulnar nerve. So now we have got the answer here. The carpal tunnel, definitely the part here, because the median nerve is passing through it, but the test which is related to the median nerve, that is the Durkin test, okay. Yes, now this is the next question, which is again the image based question here. This is a microscopic slide is given here, and this is the slide of the kidney, okay. Now some of you may have given this point here, okay. This may have marked this option for the answer here, but the answer for this is the renal glomeruli. So in this case, the marked structure is the glomerulus, okay. Surrounding it has two layer, parietal and the visceral layer here, and in between this space you can see. So with the help of this, you can say this is the slide of the kidney, and the marked structure is the renal glomeruli, okay. Now if it is a slide of the pancreas, so you just need, there will be some this kind of appearance will be there, but there will be no space. You just need to see the surroundings as well, okay. If there is a slide, if this is a slide of pancreas, then and there should be serous acini, there should be some other structures related to it, but here we have the renal glomeruli, okay. This is the and you can see the PCT and DCT are here. The one which is with the hazy lumen, that is the PCT, and with the clear lumen, that is the distal convoluted tubule. So when you are seeing any when you are seeing this kind of images, no, so you just not only focus on the marked area, you just have to look the surrounding structures to have a clear idea about the structure. So the answer is here renal glomeruli. Yes. Now we have the next question here. A 30-year-old patient presented with a midline swelling which move up with the tongue protrusion, okay. So what is the diagnosis here? And these are the options. So here in the midline there is a swelling and which moves with the protrusion of the tongue. So definitely it is a thyroglossal cyst here, okay. For this we will see this part here. So here you can see this is a development of the pharyngeal arches here. Between the first and second pharyngeal arch, you will see there is a foramen which is called as the foramen cecum just above the tubercular impar, okay. Now from this foramen cecum, the duct is growing here which is called as the thyroglossal duct. This duct it will keep growing downwardly here, and then it will divide into the lobes to form the thyroid gland here, and then finally the thyroid gland, with this process it will reach here to just in front of your thyroid cartilage, and occupy its final position here. So that's how the thyroid gland, it starts developing from this foramen cecum here, and all the way it will go downwardly and finally reach to its position. Okay, so this is the migratory pathway of the thyroid gland. Now if we will talk about the remnant of the thyroglossal duct here. See, so the proximal part of the thyroglossal duct, okay, it will form a remnant here which is called as the foramen cecum. So this foramen cecum, it is present at the junction of the anterior 2/3 and posterior 1/3 of the tongue, which is the indication of the development of the thyroglossal duct. Okay, so this is the proximal remnant here. Now in the distal part of this thyroglossal duct, it will form the pyramidal lobe here, which is just over the isthmus of the thyroid gland here. So these are the usual remnant of the thyroglossal duct. Okay, in between this part will be disappeared here, but if during the migration of the thyroid gland, okay, during its pathway, whenever there is this thyroglossal duct, if it persists here, so it will form a cyst which is called as the thyroglossal cyst. Okay, so throughout the migration of the thyroid gland from tongue to the this position here, just in front of the inferior and below to this thyroid cartilage here. So here in these places you may find the remnant of the thyroglossal duct, and that is considered as the thyroglossal cyst. So you can find it at the junction of the anterior 2/3 and posterior 1/3 of the tongue, above and below and in front of the hyoid bone, in front of the thyroid cartilage here you can find the thyroglossal cyst. Now suppose there is a thyroglossal cyst in the midline here, so it is connected to this foramen cecum, or which is present here within the tongue with the remnant with the persistent part of the thyroglossal duct here. So what will happen when you will take tongue out from the oral cavity, when there will be the protrusion of the tongue, this swelling will move. Okay, and that is happening here with this case. There is a midline swelling in the neck, but it is moving with the protrusion of the tongue, so most likely the diagnosis is the thyroglossal duct. Okay, now we have other options like ranula, this brachial cyst, and the dermoid cyst here. Branchial cyst is it. Okay, now for this you can see this these images here. This is the ranula, which occurs in the floor of the mouth, basically due to the blockage of the salivary glands. This is the branchial cyst. Why it appears? Because there is a cervical sinus. Okay, so persistent cervical sinus will form a swelling here, which is called as the branchial cyst, and you can find it along the sternocleidomastoid muscle. Now there is another condition which is the dermoid. So dermoid, basically it is due to the that non-fusion of the layer of the skin and any defect in the layer of the skin here. So if it is present in the midline here, okay, then it will not move with the protrusion of the tongue, because it is not connected with the underlying structures. So these are all the all other options related to this question here, and we have this thyroglossal cyst, which is the answer for this question. Okay, so this is all about this recall session from my side, and very soon we will come with the another session where you can find the approximated questions which were asked in the NEET PG 2023, especially the anatomy part. I'll discuss with you guys, and if you have any queries, any suggestions, you can put your comments in the comment box. So thanks for watching, and all the very best for the students who are preparing for their upcoming exams. I hope this session will help you. Thank you.